Good evening, everyone, and welcome back to the Lipid Panel. My name is Dr. Guy Mintz, and I'm the co-chair of programming with Dr. Merle Myerson, and we're working alongside this evening Amanda Hicks from the National Lipid Association. The Lipid Panel was conceived to be a lipid clinic conference on a national scale. For those of us lucky enough to have in-house colleagues, a lipid clinic experience or conference is a great way to debrief after a busy day of clinic, review diagnostic approaches, how to interpret clinical findings, and generate therapeutic strategies to come together with colleagues. For the rest of us who feel like we're on lipid islands, conferences like this remind you that you're not alone. If you have cases that you want to be presented at future conferences of the Lipid Panel, please email Amanda Hicks at ahicks@lipid.org with your suggestions. In this series, we review common presentations of rare diseases, atypical presentation of common conditions, sometimes even common presentations of common conditions, and we will try to cover as much and as many important clinical topics every lipid specialist needs to know. The series is meant to be a monthly coming together of rising stars like the FNLA lipid scholars and early career lipid specialists with more experienced colleagues. Look for our schedule posting for the final Tuesday of every month. This evening, I am joined by a superb panel for our discussion. We have Dr. Dean Karalis, will be our moderator. He's professor of cardiology at Jefferson University and has conducted many trials in the area of cholesterol lowering and has written over 100 articles, book chapters, and abstracts in the area of lipid management. We have Dr. Samia Mora, who is a cardiologist and molecular epidemiologist conducting translational research in the prevention of cardiometabolic disease. She's professor of medicine at Harvard Medical School, the director of the Center for Lipid Metabolics and director of the Biorepository Divisions of Preventive and Cardiovascular Medicine at the Brigham and Women's Hospital. We also have Dr. Robert Block with us as a panelist. He's professor and director of the University of Rochester Cardiology Division of the Department of Medicine's Clinical Lipidology and LDL apheresis program. And he is the director of epidemiology and prevention of cardiovascular disease course at the University of Rochester. And presenting our case this evening, we have Dr. Tia Bimal, who is our preventive cardiology fellow at Lenox Hill Hospital, the Northwell University Health System. So it is my pleasure to introduce this dynamic panel and moderator for tonight's presentation. So Dr. Bimal, Dr. Karalis, take it away.
Great. Well, welcome, everybody. I'm looking forward to a really exciting discussion this evening. And Dr. Bimal, why don't you start and present the case?
Okay, so we have a 56-year-old African-American obese female who presents for a lipid consult. So a brief overview. So at 40 years of age, she was diagnosed with non-insulin dependent diabetes. At the same time, she also was diagnosed with hyperlipidemia and statins were started. At 47 years, she had menopause. At 50 years of age, she received her very first coronary artery stent. 6 months after, she received another stent. At 52 years of age, she had her first MI, balloon angioplasty, and brachytherapy. At 53 years of age, she had 2 more stents placed. At 55, she had stent number 5 and a cabbage. At 56 years of age, she had a balloon angioplasty, stent number 6 in her native coronary artery, and stenosis of her bypass graft was also found at this time. Her cardiometabolic risk factors include hyperlipidemia, diabetes, and obesity. In terms of current medications, she's on aspirin, 81 milligrams daily, clopidogrel, metoprolol succinate, 25 milligrams daily, dapagliflozin, 10 milligrams daily, semaglutide, 2 milligrams weekly injection, rosuvastatin, 40 milligrams daily, and evolocumab, 140 milligrams biweekly injection. In terms of lifestyle, she has a pretty good lifestyle overall. She walks daily. She's a pescatarian currently. She's a never smoker, occasional drinker, no illicit drugs. In terms of family history, the paternal family history is significant for early heart disease. So father had a CABG in his mid-50s, passed away from an MI at age 78. It's uncertain if he was ever on statins. Mother did have hyperlipidemia, and she's still living. She's on statins. Paternal siblings had hyperlipidemia and diabetes. Maternal siblings, however, are in good health and no children. In terms of review of systems, patient did complain of chest pain when she presented to us. And this chest pain radiates to her left arm, and she had associated palpitations after walking 1 block. And both of these symptoms resolved with rest.
Now, before we get into some of the lab data, Dr. Bill, maybe you can kind of help us out and tell, what were you thinking when you saw this patient in the office? What was your thought process that was going on?
So at this point, we're thinking that, this is a high-risk patient, and this patient has progressive, recurrent coronary artery disease. And we should further risk stratify her with, specialized lipid tests such as LPA, and also other tests such as HSCRP. And we also got lipid panels on her to see where she is and how she could be better managed. That's what we were thinking.
But I think I kind of set you up now so we can talk a little bit, and you can go into some more of the vitals and the lab work.
Okay, so in terms of the vitals, vitals were significant for a BMI of 33, so she was obese. Physical exam was normal. In terms of labs, her CBC was normal. On the BMP, the creatinine was 1.5 and her eGFR was 41. We don't have her baseline kidney function. She had gone to multiple different hospitals before coming to us, so we're still in the process of gathering all her records. In terms of the liver function tests, they were normal. A1C was significant for was 7.5, was elevated. The carotid Doppler was normal, ECG as well was normal. And her most recent coronary angiogram was notable for mild disease in the right coronary artery and in the LAD, and the proximal ramus had 70 to 80% in-stent restenosis, and a stent was placed. Her CABG anatomy was not available at this time. In terms of her lipid panel, so she came to us around October, November of this year, but leading up to it, her LDL was well controlled for the most part with the rosuvastatin 40 and evolocumab biweekly injections. In November, however, she missed 1 to 2 doses of the evolocumab, and therefore her LDL was elevated to 85. In terms of her baseline LDL, in her early 40s, when she first started statins, prior to that, it was around 120 to 210. The first time she ever got a lipoprotein A was this year in 2023, prior to her 6th stent, and it was elevated to greater than 600 nanomoles per liter. And this was measured by her primary cardiologist. We remeasured her when she came to us, and she was 627 nanomoles per liter. Her HSCRP was 2.61, and her ApoB was 84.
And I think we probably would have expected the ApoB to have been lower if she had been compliant with the evolocumab at the time. So I think what really stands out in this case is the aggressive and progressive coronary disease and how severely elevated her Lp(a) is. So maybe as a backdrop, maybe Dr. Mora, can you kind of go over with us and for the group, what is Lp(a)? How do you think it's associated with the risk in this patient?
This is a great case highlighting many important factors relating to Lpa and to lipids. First, Lpa is not really an LDL-like particle, although you may see many articles written that say LDL-like particle. It's really not like LDL, but it has some similarities in terms of there's an ApoB that is central to the LPA particle. And then that ApoB has attached to it an ApoA, an apolittle particle that's attached to it. And Lp(a) is now thought to be a causal lipoprotein particle that's related to cardiovascular disease in terms of both MI, ischemic stroke, especially at very high levels of Lp(a), and also aortic stenosis. It's actually the only lipid or lipoprotein genetic risk factors for aortic stenosis. Lp(a) is also predominantly genetically inherited and genetically determined. So over 90 or 95% of Lp(a) is really determined by our genetics. So we cannot really modify our genetics, but we can modify the milieu, the other risk factors, and we'll get into that a bit later. Another key thing is this lady is African American. Blacks have higher Lp(a) levels than whites and than other ethnicities. There is a significant racial ethnic difference in Lp(a) levels. Again, Lp(a) is driven by genetics. Nonetheless, this woman has really high, very, very high Lp(a) level in terms of the level of over 600 nanomole per liter. There's a few things we can get into in terms of the assay. The nanomole per, one thing to know is that the level can be very different depending on the assay that's used. Milligram per deciliter is an assay that's measuring Lp(a) mass. There are some assays that measure Lp(a) cholesterol that are also reported as milligram per deciliter, but for the most part, milligram per deciliter is measuring the whole Lp(a) mass, so the Lp(a) ApoB mass as well as the Lp(a) cholesterol mass, all the Lp(a) mass there. Nanomole per liter is measuring the concentration of Lp(a) particles. So how many particles do we have of Lp(a) per unit volume? And as you can see, the two are very different, and it's now recommended to measure it through the nanomole per liter, which is particle-based measure. But a lot of assays are out there, and the important thing is to know what assay and to try to use the same assay in the same lab in order to be able to interpret any differences across assays.
Yeah, I want to follow up on something you said. We can comment on it a little bit more. We know there are differences in Lp level between gender, between race, and consistent. But is there a difference in cardiovascular risk if the Lp(a) is elevated based on race or based on gender?
What we know is that if the Lp(a) level is high, it's going to carry increased cardiovascular risk regardless of the race ethnicity. Now, to be fair, most of the studies have been conducted in whites or individuals of European or Caucasian ancestry, but there are quite a few studies now also with a significant number of Black participants, like the ARIC study, the UK Biobank study. We know much less about other ethnicities, but we do know that there are variances across levels, but the risk is there for, as far as we know, across all ethnicities. And that's why pretty much all the guidelines or consensus statements and even the recommendations don't really differentiate risk based on background of race, ethnicity.
Gender, and ethnic, and racial, and neutral. I want to get Dr. Block into this conversation. Dr. Block, maybe you can talk to us a little bit about, what are the cutoffs for Lp(a) levels that are associated with risk, and does that risk increase the higher the levels? I mean, this patient's Lp(a) is really very, very high, but maybe you can give us some insight as to, what are the levels that are associated with risk, and tell us a little more about that.
Sure. So basically, depending upon whether it's milligram per deciliter or nanomoles, basically there's a sort of some differences. For example, the most highly internationally respected high level of with milligrams per deciliter, as that measurement is basically greater than 50. However, at the same time, I just want to make sure everybody knows that the higher the worse. So basically there's thresholds, and we all know that oftentimes it's easier for us as clinicians and patients to sort of separate and say, well, it's high or it's low, but basically that the higher the worse. Regarding risk and the processes in which basically lipoprotein A increases risk And then also, so that with nanomolds, is basically the threshold is generally respected to be greater than 75, which is quite a bit higher. And as you could tell, again, with this particular patient, it's much higher than that. And many people actually would say that the nanomoles is a bit more highly respected, largely based on what Dr. Mora had said. But basically, labs use either one. And as far as I know, they're both actually still valid. One may be a little bit better than the other, but I wouldn't necessarily differentiate them as far as saying one is not worth measuring.
And if we look at her baseline LDL cholesterol, at baseline it's severely elevated, and we know that when we measure LDL, in fact, part of the cholesterol that's carried on Lp(a) is actually measured when we measure LDL cholesterol. So, do you think this patient could have FH? Could we be misled by that, or is really most of her risk associated with her Lp(a)? And Dr. Blaga, I'll let you kind of finish and maybe comment on a little bit more about that.
Sure, that's a great question. So regarding familial hypercholesterolemia, obviously there's different ways of differentiating as to whether or not someone has it or not. There's the Simon-Broom criteria, which was from England, and then there's Dutch criteria from the Netherlands, which require physical exam, at least as options for declaring if someone has familial hypercholesterolemia or not, based on things like tendon xanthomas, particularly in the Achilles tendons, and arcus senilis, basically discoloration of parts of the eye. But basically, there's also something called MedPed criteria, which just takes into account someone's age and their highest LDL cholesterol, and also can take into account some family history. But basically, and there's also genetic testing for that, which many people we know undergo that test, and it can be positive. So that's one good way of differentiating people with familial hypercholesterolemia. Whereas actually, we know that test is not perfect, only about 60–80% specificity for the, or I should say sensitivity for the genetic testing. But basically, the other issue is that there's a lot of good reason to consider actually what Dr. Karalis just said, which is that lipoprotein A, because it does contribute to the higher LDL levels, makes it even more important to use those kinds of ways of differentiating or diagnosing, people who have familial hypercholesterolemia. So I'd be a little bit more reluctant of concluding that this patient has, an LDL greater than or equal to 190, which is normally thought of as a threshold for adults when considering familial hypercholesterolemia.
So I guess the point is if your LDL cholesterol is severely elevated, we should think that Lp(a) could be contributing and measured in those patients. So I want to kind of expand on that. And Dr. Mora, I know the European guidelines are recommending pretty much checking Lp(a) once in someone's lifetime. We don't have quite those guidelines, but what are you doing in your practice? What are your recommendations? When should we measure Lp(a)? How often should we measure it? At what age? Maybe you can give us some insight into that.
Yeah, I have to, in the interest of complete disclosure, say that I was co-chair of the European Atherosclerosis Society committee that you just referenced in terms of the recommendations.
You're the right person to ask this question.
So I'm completely in agreement with our conclusion that everybody should get an Lp(a) measured once in their lifetime at least. Probably in most people you don't need to remeasure it. Some people you may need to. And the reason we came to that consensus was because of several things. One is Lp(a), unlike LDL cholesterol, unlike other lipids, doesn't get measured frequently. In fact, even by cardiologists, even at top academic centers that have the best assays, etc., we're just not measuring it frequently enough. This case actually is a great example of that. This young woman who had premature cardiovascular disease, it took multiple providers, multiple admissions before she got her Lp(a) measured. And that is very typical. We see that. So part of the reason that the EAS consensus statement recommended getting Lp(a) measured at least once is in order to pick up that risk, that genetic risk. There's another reason, because now that this woman we know has an extremely high Lp(a), this is extremely high. It's probably in the top, 0.5%, really high Lpa level. So we have to also screen her family. She doesn't have children, but she does have first degree relatives, like siblings, that should be checked, as well, her, or her mother if she's still alive. And so the reason for that is that you identify through cascade screening and through general screening individuals that have very high or high Lpa levels, even if they're not very high, but that is a causal risk factor, as I said, now we recognize, for cardiovascular disease. And therefore that informs that person's risk. So we can take into account her Lpa related risk in addition to all her other risk from the other risk factors, as in her LDL cholesterol, her diabetes, her, of course, premature coronary disease, etc. So in her case, probably her Lpa related risk is at least 3 times fold or 4 times fold that compared to somebody of all her other risk factors, but without having such a very high Lpa level.
Yeah, those are good points. Now, Dr. Block, I'd like you to comment on something as well. Her measured ApoB in November was 84, but we know she had missed several doses of the evolocumab at the time. It's likely that if you had measured her ApoB earlier, when her LDL cholesterol was around 50, it would have probably been a lot lower. And we know that Lp(a) is an ApoB containing lipoprotein, but there's not a good correlation when Lp(a) is very high with ApoB. So, we can miss these patients if we just focus on ApoB. Maybe you can comment a little bit about the relationship with ApoB, with Lp(a), and that the Lp(a) particles are much more atherogenic than single LDL particles.
Yeah, so basically what I would say about that is that again, getting back to what we've been discussing so far, is that lipoprotein A is sort of like an independent risk factor. So even though the ApoB and the LDL basically could be somewhat affected potentially by a high lipoprotein A, if someone has a high lipoprotein A, then it basically, because it's an independent risk factor, we need to take that into account, by itself. And again, the higher the worse. And generally speaking, what we know is that lower levels of ApoB than 80 are very, very safe. And in particular, one thing I'm thinking about is that even though we don't have any current medications, which specifically we know directly just lower lipoprotein A and lower risk for heart attacks and strokes by doing that, there are other medications that we'll show you later, but basically that have effects on it. What we try to focus on is other risk factors. And as time goes on, what we have known is that partly because epidemiologic studies, observational studies, and clinical trials of statins, et cetera, and PCSK9 inhibitors like alirocumab and evolocumab, basically lower levels of LDL, which correlate way below 70 and correlate much even lower than 55, which correlates with an ApoB generally under 80. We know that's very, very safe. And to completely figure out whether or not lipoprotein A is contributing or not to those higher levels, I'm not fully aware of a specific way of doing that. And that would also change management, effectively change management.
That's kind of a good inroad. I want to change the conversation a little bit and get into treatment. So, this patient's been on a high intensity statin now for several years. And we know statins can sometimes actually raise Lp(a). So, Dr. Mora, can you give us your thoughts about, what are the role of statins, in patients with high Lp(a)? Should we be concerned if the Lp(a) goes up a little bit? And is there any role for lifestyle here, in good diet? And how does that impact the risk associated with Lp(a)?
Yeah, so statins reduce cardiovascular risk by about 20-30%. Statins reduce LDL cholesterol up to 50% with this high intensity dose that she's on. And statins may, in some individuals, we don't know in her because we don't have an LPA level before she was put on the statin, but statins may in some individuals raise the Lp(a). Usually we see that about like maybe 10% or so. In some individuals with very high LPA to start with, it can raise it more than 10%. However, in most people who's go on statins, it doesn't affect the LPA. We know that from population studies, from clinical trials, like in the Jupiter study that we conducted, the overall LPA did not change on average, but we did notice that there were some patients, especially at the higher levels of LPA, that may have increased. So, so we don't worry so much about the increase in the LPA because, about a 10% or even 20% increase in LPA level related to a statin doesn't necessarily, change our management because we know the statins are reducing cardiovascular risk. So they're reducing MIs, stroke, cardiovascular death. And even if they cause, and like I said, in most people, they don't cause elevation in LPA, but in some patients they may, but it's usually a small amount. So we still use statins. We don't worry about the slight increase in LPA. There are other agents like this patient is on PCSK9 inhibitor. Again, we don't know if she was one of those people who responded also in terms of her LPA with the PCSK9 inhibitor, evolocumab. In general, with evolocumab, with alirocumab, there's some inter-individual variability in terms of the LPA responses. On average, we see about 20 or 25%, maybe up to 30% reduction in LPA levels. But that reduction in LPA level is actually the proportional percent reduction in LPA is even less among individuals who have high LPA. Those are the individuals we want to reduce more of their LPA, but with PCSK9 inhibitors, as far as we know now, they actually have less of a reduction among individuals with high LPA. So again, there's a lot of inter-individual variability, and we don't know in her because we don't have her prior LPA level in order to know how did it change. And there was a third part of your question, diet. It's interesting. I was involved in a randomized trial where individuals were randomized to lose weight and then kind of various ways randomized after that to diet. And one of them was a low carb, high fat diet. And if you do a low fat, high carb, low carb, high fat diet, it actually reduces LPA levels by about 10 or 15%. So potentially you could recommend a diet that's more, of a healthy fat, so sort of more of a Mediterranean type diet. She is, I noted she is a pescatarian. And so, in general, higher fat is associated with lower LPA. We want to avoid trans fats, of course, in patients because that can actually increase the LPA.
So I'm going to invite Dr. Bimal back, and maybe she can kind of, so this patient has now really a low LDL cholesterol, high intensity statin on a PCSK9 inhibitor. So maybe you can tell us what your thought process was and what you did to further treat this patient.
Okay, so, there were considerations of, us enrolling her in like a trial of medications to lower the LPA, like the OCEAN(a) trial. But the only problem with that was the patient was having progressive disease, and we didn't want to risk her getting the placebo potentially. So because of that, we decided the next best option for her would be to do lipoprotein apheresis. So, Dr. Mintz has been trying to help with this process, and she has gotten approved for it. And she's potentially going to start next month with the apheresis.
So we're going to talk a little bit later about some new agents, that lower Lp(a) that are now in clinical trials. But I know we have a few slides, and I wonder if you can kind of go over us with Dr. Bimal, kind of give what are the indications, and I think we have some slides that I can put up. Let's click this. What are the indications for apheresis in this country? and then maybe you can share some of the data from some of the German experience.
Sure. So in the US, currently apheresis is approved for homozygous FH when the LDL is greater than 500, for heterozygous FH when the LDL is greater than 300, and for heterozygous FH patients who have LDL greater than 100 on maximal possible drug therapy and with coronary artery disease or peripheral artery disease. In heterozygous FH patients with an LPA greater than 60 milligrams per deciliter, which is 120 nanomoles per liter, on maximal possible drug therapy with coronary artery disease or peripheral artery disease, and LDL greater than 100 for FSGS patients. So adult and pediatric FSGS patients with nephrotic syndrome and eGFR greater than 60, and also post-renal transplantation FSGS patients.
So these are really just guidelines for indicated use for apheresis. So how are you able to get this patient's insurance company to approve apheresis for this patient?
So in Germany, in Europe, there are separate guidelines for apheresis. So there is this paper that was published within the German group. And basically, since 2008, an elevation of lipoprotein A along with progressive ASCVD has been an indication for regular lipoprotein apheresis in Germany. So there's this GLAR registry, which is a German lipoprotein apheresis registry, which was initiated to provide safety and efficacy of lipoprotein apheresis to treat severe hypercholesterolemia, particularly in patients with familial forms and lipoprotein A hyperlipoproteinemia with progressive ASCVD. So this registry had a group B, and this subgroup B had patients similar to ours who had an LDL less than 100, but a lipoprotein A greater than 60 milligrams per deciliter. And the outcomes of this trial was MACE, which is major coronary events, and also major non-coronary events at 1 and 2 years.
And I think you have a slide that kind of shows some of these results.
Exactly. So in these patients, so in this subset with the LDL less than 100 and a lipoprotein A greater than 60 milligrams per deciliter, the major coronary events decreased by 83% and subsequently 86% in the first and second years with lipoprotein apheresis, and the non-coronary events decreased by 50 and 64% in the first and second years after lipoprotein apheresis. So with this data, we were able to help get approval for our patient.
And how much does apheresis lower Lp(a), and how often are you doing apheresis in these patients?
So usually we do it either weekly or biweekly, yeah, and basically it should lower it by about 60%.
So really dramatic, and I think we know from some of the genetic studies that we need to significantly lower Lp(a) if we hope to see some type of cardiovascular benefit. But not all patients might be amenable to apheresis. Patients may not be approved by their insurance companies. I want to kind of switch gears a little bit, and maybe Dr. Mora, can you kind of give us an update on what some of the new medications now that are being evaluated in clinical trials for lowering of Lp(a)?
Yeah, as I said, at the beginning, LPA has two components, ApoB and ApoA. The ApoA, and so these, targeting either one of those components will reduce the LPA. This patient, I think, would be a great patient to enroll in one of the current phase 3 clinical trials that are testing some of the LPA specific lowering therapies. So the ones that lower specifically the target, the LPA levels. And there's a few that now we know can reduce LPA substantially meaning like up to even 95, 99% in some of the latest studies. And that's dramatic lowering of LPA levels. And somebody like this patient would be perfect for one of those trials. We currently don't know if lowering LPA specifically will reduce cardiovascular events, but that is what's being tested. But we do know that there are these several agents that target the ApoA production that basically also reduce LPA levels substantially. There's an antisense oligonucleotide drug. It's called pelacarsen. That's currently being tested in a phase 3 randomized clinical trial. I think we expect the results in another year or so. There's olpasiran and lepodisiran. These are siRNA technologies. siRNA and ASO both target the production of the LPA. The ASO's antisense oligonucleotides act more in the nucleus, and the siRNA act more in the cytoplasm. But regardless, either way, they both reduce the LPA production, specifically in the liver. There's another silencing siRNA technology that's longer acting, SLN 360, which is now I think it's called Zalarisan, that also reduces substantially the LPA production. Now, that's one way to reduce LPA. Those are several. There's now a few randomized phase 3 clinical trials. There's another type of drug, obicetrapib, which is a CETP inhibitor, cholesterol ester transfer protein inhibitor. And this is, it reduces LPA by quite a bit, about 50%, not as much as the other ones I just mentioned, the RNA or ASO inhibitors. Now, obicetrapib, we don't know how it actually reduces LPA. So the mechanism of how it reduces LPA is not really clear. There are also some other agents that inhibit ApoB production. That's the ApoB part of the LPA. And those can also reduce LPA, but more in the modest range, like up to 30, 40%.
I'm also looking and maybe we can kind of just jump back a little bit. What do you think about if this patient wasn't approved for apheresis, we couldn't get them into a clinical trial? Is there any role for high dose niacin in a patient like this? And is that something you would consider? And we'll make the assumption that her diabetes is well controlled and we're not at risk of worsening her diabetic. So is there any role here for niacin, in this case?
That's a good question. So niacin, from what we know from the randomized trials, on top of a statin, which this patient is on, there's no evidence that will improve or reduce her cardiovascular event rate. Now, we do know that niacin will reduce Lp(a) by probably about 20, 30, 40%, something in that range. And that we also know that some patients tolerate it. It can worsen insulin resistance, it can cause gout, etc. And flushing. But the issue with niacin, why a lot of us have now veered away from it, is because the randomized trials that were conducted did not show benefit on top of a statin. There's some older data suggesting that niacin has benefit, that showed benefit among one of the very old trials from years ago, that there was benefit for niacin in patients not treated with statin. So, if you're trying to prevent clinical outcome, which I think is our main concern in her, I don't think we have really good proof or any proof really that niacin in this, in the modern era, contemporary era, would work. She is already on a PCSK9 inhibitor, which would be expected to reduce her LPA again by about 15, 20%, something in that range. Not all patients though respond. There are some other agents, again, that one could use, like in a woman who's postmenopausal, hormone therapy, estrogen therapy could be potentially considered. However, again, there's all, from the clinical trials, there's increased risk for for combination therapy in terms of coronary disease, like for estrogen and progesterone, and even estrogen alone was associated with increased risk of stroke. While there is some suggestive data that if you start hormone therapy early on after menopause, you may not get that increased risk, the data is really weak. So again, we don't usually use hormone therapy either in order to reduce our cardiovascular disease risk, even though it may reduce our LPA level by about 20% or so.
Right, especially in someone with this advanced coronary disease. So this is a case of secondary prevention. So I'm gonna take the liberty as the moderator, and I'm gonna sort of give you another case for primary prevention. I'd like to have both your inputs. So we know that LP(a) is almost all genetically determined, and there's a high risk. So let's just say that she does have a child who's 30 years old, 25 to 30-year-old woman, premenopausal, childbearing age, otherwise healthy. We measure her LP(a) and it's severely elevated. So how would you handle this younger individual now who's 25 to 30 years old, of childbearing age, and has a very high LP(a)? So maybe Dr. Block, I'll start with you, and I know this is a gray area, so whatever I'm not going to hold you to anything you say, even though this is being recorded, but I want your thoughts as to how you would manage that patient. Is there a role for aspirin for high LP(a) in primary prevention, statins, et cetera? So how would you deal with the child of this woman who now has also very high LP(a)?
Yeah, so it's a great question, and basically, getting back to the fact that yes, we do expect that there's likely going to be at least one drug that will be approved by the FDA that lowers lipoprotein A and lowers risk for cardiovascular disease in the next few years or so. But basically, right now, what we have is the general conclusions made by many people, like including many other people in the National Lipid Association, that when you look at the data, since there's so much data supporting lowering other risk factors, like if she's got an LDL cholesterol that's well above 100, it's very reasonable to have her adapt a healthier lifestyle if that's appropriate for her, and to consider potentially taking a statin. You can estimate her cardiovascular disease risk using the ACC/HA guidelines, which have been endorsed by many other reputable groups. Of course, as been alluded to already by Dr. Mora, that's certainly not perfect, but it's a way of also helping her to think about like long-term lifetime risk and what we can do to manage that. And so improving her lifestyle, and also considering the fact that aspirin does lower lipoprotein A. However, I'm not aware of full knowledge as to that lowering risk in someone like that. But again, it really relates to risk versus benefits, right? If you're high bleeding risk, which usually a young woman is not, for GI bleeding, et cetera, then it'd be very reasonable for them to take 81 milligrams of aspirin per day. But there's also evidence supporting even lower doses. So if she even wanted to take it as 3 days a week, 81 milligrams a day, there's still some evidence to support that does reduce, cardiovascular disease risk. So it's kind of getting back to those other things. And also the other thing is that a high seafood diet, shown in a study published many years ago in the ATVB Journal of the American Heart Association, showed that two different genetically sane populations in Africa had very different diets, because some lived on the coast and ate much more in the way of seafood. So their levels of EPA and DHA were higher, but basically there were different levels of lower levels of lipoprotein A in that population. So part of my point is that getting back to some of the current evidence, like through the Predimed study published in the New England Journal of Medicine 2018, we know that simply eating a Mediterranean diet with oily fish in it is heart healthy. They didn't differentiate if people had a high lipoprotein A or not, but still, it's a safe, effective way of reducing their risk. And it brings up this issue of cascade screening, which I think is really important, is that basically there may be other siblings of her, this daughter, other genetic relatives who may also have a high level. And so it's not that we have no tools in the toolbox to try to help, prevent cardiovascular disease risk.
So, and Dr. Mora, so I think, so consider statin, lifestyle, make sure she's not diabetic, consider aspirin. Maybe you can expand on that a little bit and some of the genetic studies with aspirin.
Yeah, actually we, I think the aspirin story is yet to be, concluded. We still don't know all the story there, but what we do know is now we have 2 randomized trials where LPA was measured in terms of the Women's Health Study, a study conducted from the Brigham and Women's Hospital, and we had about 40,000 women. About 28,000 of them had LPA levels measured, and the average age at the study enrollment was about 55 or so. And what we found there was in a study led by Dr. Dan Chasman. We found that there was a polymorphism in LPA that among those women that had that, they had about 2-fold increased risk of CVD events during over a 10-year follow-up. But those that were half the population got aspirin, low dose aspirin, as Dr. Block was saying, was actually 100 milligrams every other day, so about 50 milligrams a day. They had actually substantial reduction in that LPA related risk by about 50%. And so that study was ignored for a while. That one was published over 10 years ago, until actually the ESPRI trial came about, and then there was a recent study that was published about a year ago now in ESPRI, where they didn't measure LPA levels, but they looked at the same LPA polymorphism that was identified in the Women's Health Study. They had genetics on a subgroup in ESPRI. Again, these are all white individuals that they were looking at, as in Women's Health Study also, because the genetics at that time was sort of more geared towards that. And also in ESPRI found the same thing, that among individuals who carry the specific LPA polymorphism, low dose aspirin they had increased risk of CVD, and the low dose aspirin substantially reduced their CVD. And even they did a genetic risk score of about 48 or so, 43 variants in LPA. And that identified basically about the top 20% estimated LPA levels based on the genetic risk score. As we said, LPA is mostly genetic. So they identified like sort of, genetic polymorphisms, grouped them together as this genetic risk score. The individuals with the top 20% of this genetic risk score, they also looked to see, and they also had increased risk of CVD. And if they got aspirin compared to placebo, that risk was lowered. So these are now 2 trials that we have that examine this question, even though this wasn't the primary endpoint of either trial, but this is now very consistent data. So I agree with Dr. Block that aspirin in a patient who doesn't have any other indication for aspirin, for example, in primary prevention, we're trying to decide, and if the patient has a low bleeding risk, meaning they don't have any GI ulcers or history of bleeding disorders, etc., they're younger. The woman you mentioned for primary prevention was younger, and the bleeding risk with aspirin is really when individuals are over 70 or 75. So aspirin, I think, is very reasonable to consider. I agree with Dr. Block that for primary prevention, I would calculate the patient's overall cardiovascular risk. We have many risk scores out there. There's the pooled cohort equation. There's most recently now the PREVENT AHA risk equation. But regardless, assess their overall risk. If they're young though, and they're a woman, their overall ASCVD risk is going to be generally, less than 1%. It's going to be low, even if they have multiple risk factors. So then I really think you have to look at their lifetime risk. If the patient the prime prevention patient that you mentioned is the daughter of the current patient who already we know has premature CVD, we already know has a very high LPA, so we know that her child will also have that risk, at least from the genetic aspect. She already has a very high LPA. So I would look at her other risk factors. I would try to assess her lifetime risk. There is a calculator, by the way, for people out there that's available and free. It's called LPA Guidance, LPA clinical guidance, and that was developed by Brian Ferentz with basically using the UK Biobank data. But I encourage everybody to look at it because it has in it, you can estimate the patient's lifetime risk and then how much of that risk could be related to the LPA level itself. You can plug in there the LPA level and how much would you have to modify the other risk factors in order to counter that risk over a lifetime. And I would again concur with Dr. Block that you really have to manage all the other risk factors that we know, could reduce the risk, overall risk for cardiovascular disease, including a Mediterranean type diet that we know benefits by about 30% reduction in CVD events. We know that statins reduce risk, and we know that statins, by the way, work as well among individuals with low or high LPA. We did that study in Jupiter, but others have done it in other studies, and we definitely know that statins reduce CVD risk, again, by about 20-30% among individuals, regardless of their LPA, if it's high or low.
Yeah, I think these are all excellent points. We probably have about 5 or 10 minutes left, and I want to we've gotten several questions in the chat box, so I want to open them up, to our panelists. So one
elevation of risk factors that put Torsay in a metabolic syndrome category. So I would try to aggressively address all of these as well while we wait the clinical outcomes trial. And if they meet criteria, as in the patient that we're discussing, who would meet criteria, for putting her in a clinical trial, I would definitely discuss that with the patient, and as well as the apheresis option. This is again for our patient with the significant coronary disease.
So I think these are all really good points. So we have about 5-10 minutes left, and I want to get to some of these questions. So one of the questions came up with regard to apheresis, and maybe Dr. Block, you can start, and Dr. Mora chime in. Would you do this weekly? Would you do this bi-weekly? And how would you handle how often you would do the apheresis?
Yeah, great question. So I would just take a first step at this and say that a lot of it really depends on the patient's abilities, their time, obviously, because what's feasible for them, because apheresis takes maybe up to 4 or so hours to come in and have those treatments done properly. But at the same time, because of this patient having such high risk, I think it would be very, very reasonable to recommend that they be treated every week, because we know they also, getting back to the other thoughts we had before, was if the LDL cholesterol is even lower, then basically that correlates with a lower long-term risk, for cardiovascular disease events. But I'll let Dr. Mintz and also Bimal share their thoughts.
Well, I think, turn on my video. I think, it may be an individualized effect. I mean, with the patient, we'll start bi-weekly and see where we go with regards to the LDL and the LPA. And if we need to go weekly, then we will and go from there. And before I hand it over to Dr. Mora, there was another question about getting approval for the apheresis for LPA. And it's really based on insurance, because some insurance recognize LPA as a risk factor. And the other factor in this case was the LDL was not at target. It was below 100, but it was not at target. And there are many insurances that would negate apheresis, but there are some insurances that, will cover it case by case basis. So that's an offline conversation for another day, but I'll let Dr. Mora answer the question about frequency.
Yeah, I don't have much more to add. I mean, other than that, the frequency will affect the rebound, so if the LPA level will start to rebound back up, and obviously the more frequent it is, if you do one week every week, it will, stay lower than if you do it every 2 weeks. But I don't really have much more to add about that. There was a comment also about aggressively lowering the patient's LDL cholesterol for primary prevention. I completely agree with that. I think we should start early. We often start late, especially in younger women, because if you calculate their ASCVD risk, it always ends up being sort of low. And so generally they don't meet criteria based on ASCVD risk alone. So you have to use other things like lifetime risk, or you have to look at other risk enhancing factors, which the guidelines also say to look at. And one of them is LPA, but others are CRP or inflammation, metabolic syndrome, family history, ethnicity, some pregnancy and menopause specific risk factors, etc., that can also help guide risk assessment.
So there's another question that came in. I'm going to paraphrase a little because I think it's an interesting point. And the issue is that we know that when Lp(a) is severely elevated, part of the measured LDL is actually the cholesterol that's carried on Lp(a). And there's not great ways, but we can kind of guesstimate how much is on Lp(a) versus on LDL. If you have a patient whose LDL cholesterol measured is elevated, but it's mostly Lp(a), and the LDL that's actually, the cholesterol on the LDL is actually fairly low, is there still value in trying to drive it down with intensifying statins or with ezetimibe, which we know don't really affect Lp(a), or how do we handle that patient?
Well, I mean, statins reduce CVD risk. I mean, they will reduce the LDL cholesterol, and they will reduce CVD risk regardless of your LDL cholesterol. So even though they may, you may get this what's called like kind of statin resistance among people who have high LPA, because the LDL cholesterol may not be reduced as much as you would expect, because as you said, most of the or a lot of the measurement contributing to the LDL cholesterol is coming from the LPA. In the European Atherosclerosis Society consensus, we discussed this issue, and in the end, we did not recommend for generally, for clinicians to necessarily try to estimate, but because it's a bit hard to estimate. There are formulas out there, but none of them seem really accurate, because it's hard to estimate how much of the LDL cholesterol is exactly coming from the LPA. But obviously if a patient has a very high LPA level or a high LPA, that would be contributing to the LDL cholesterol as well as to
right, maybe some anti-inflammatory effects. And we have a few more minutes, and I want to make one point, because there were a number of comments that came in, and Dr. Mora, you mentioned it about the issue with diet. That certain diets can actually raise Lp(a), but we know they lower cardiovascular, and we need more research in that field. We have a few more minutes left, and I want to talk about the elevated hsCRP in this patient. And we know that inflammation plays a key role associated with the cardiovascular risk with Lp(a). We have some role now for low dose colchicine for patients like this. We'll kind of end maybe on this note, and I'd like both your thoughts. The patient's creatinine is elevated at 1.5 milligrams per deciliter, so we have to use some caution. But do you think there's a role for colchicine in this patient who has an elevated hsCRP and a very high Lp(a)? So maybe Dr. Mora, you can start, and then Dr. Block, you can chime in afterwards.
Yeah, she would. I mean, there's definitely clinical trials showing that colchicine, especially in this patient with secondary prevention, would reduce cardiovascular events, including lowering mortality. So yes, she would be, even regardless of her CRP level. But having for a woman that's probably sort of in the above average, but in some women you can have up to 3 being sort of average in the population. So her CRP is kind of about average or above average for a woman. But regardless of her CRP level, I think she could benefit from colchicine. There was some issue about whether or not she even, she skipped evolocumab, and compliance could be an issue, and the more medications you add to a patient, the more you run that chance of non-compliance or non-adherence. But I think colchicine, I would definitely consider that in the medications to offer her, because we do have clinical trials showing benefit in a patient like her for cardiovascular event.
Dr. Block, it's 9 o'clock. You get the last word.
Yeah, I agree with that. 0.5 milligrams per day. Obviously, as Dean Karalis was basically alluding to, obviously renal dysfunction can be a bit of a concern. But generally speaking, my understanding is that people generally, with that low dose, generally tolerate it quite well. In a situation like hers, where she is an outlier, she is someone who's got big risk, not just sort of increased. And so I think in everything in medicine depends. And I think that's a great point, is that I think that colchicine should also be discussed with her.
Great. So I'm going to invite Dr. Mintz back. It's now 9:01, so we're just 1 minute over, and I'll bring him back to end the case discussion.
All right, I want to thank everyone. We could be talking for the next hour or two. Just one quick question for Dr. Mora. What age would you recommend testing LPA?
Young. The LPA levels stabilize by around age 5. The first year or two of life, they increase. So I definitely wouldn't measure them really early, because they could still increase further. So by around age 5. So anytime after that, usually, you could do it with the first lipid test, say around age 10 or so. And if they don't get it, then just measure it at any point after that. But early is fine, as long as you're not doing it the very first few months of life.
Okay, great. So obviously we can go on for the next 2 hours, but I don't want to burden our outstanding panelists, Dr. Mora, Dr. Block, Dr. Karalis, and Dr. Bimal. The lipid panel occurs the last Tuesday of every month. We have a whole lineup all set up through the end of June. Look for it to appear in the NLA newsletter and emails that come out at the beginning of each month. But if you mark your calendar, it's the last Tuesday of every month at 8 p.m. And tonight's discussion, like other lipid panels, is recorded at lipid.org and the lipid panel, so you can listen to pick up on anything else you missed this evening. Dr. Carol Kirkpatrick put in an article in the chat. Diet and LPA, does dietary change modify residual cardiovascular risk? Conferred by LPA in the journal Nutrients 2020 July. We can have Mandy add that to the site. So with that, thank you for a very stimulating discussion that was comprehensive, and really appreciate everybody taking the time to join us this evening and our panelists. So
Yes,
have a great night.
Thank you very much. And if you have ideas for future lipid panel, please let Dr. Mintz and I know. And thank you again for joining us tonight. And thank you to our panelists as well.
Thank you.